This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. This will be our last one of this calendar year. Just to remind everybody, we'll be off the next 2 weeks. The next conference will be January 11th. Hope to see you all there. And everyone have a safe holiday. Hope everything goes well for everyone. But we're going to finish with a very outstanding talk, I am sure, from Dr. Mavromatis. All of you know Kreton Mavromatis, who's a faculty member here in the Division of Cardiology. Kreton, I guess I should avoid starting out by saying he had his training a long time ago in a place far, far away, for this season. But Kreton did his training, went to medical school at Michigan, did his residency at Washington, and then we were able to attract him here as a cardiology fellow, and he did his general cardiology fellow and advanced training in interventional here. He's been a faculty member ever since. Kreton's the director of the cath lab and leads the interventional program at the VA, as well as having an important role here. He's one of the major players in our TAVR program, and is an outstanding scientist and one of the champion recruiters in clinical trials. The ischemia people keep telling me where are you in the ranking? And like top 1 or 2 recruiters in the country for the ischemia trial, and has a really strong commitment to clinical research. And today he's going to talk to us about how to manage stable coronary artery disease, give us the update, see what's new. Is it less interventions again? Is that what it is?
I won't give it away early, but yeah, I'd like to. There has been a lot of activity in the literature over the last year on stable coronary artery disease, so I thought I'd kind of update that in this talk today. We'll start out with some statistics here from 2015 from the American Heart Association. You can see that the problem of coronary heart disease continues unabated, exponential rise with age in terms of the prevalence of coronary heart disease, both in men and women. 20% of men in the 60 to 80-year-old group and 30% of men in the 80-plus group have it, with the prevalence being about half that rate in women. About half those patients actually have angina, as you can see here. About 8-9% of the men and 10% in the 80-plus-year-old group have angina, and similarly in women, which really play a big catch-up there at the end of their lives at the 80-plus-year-old age range. So it's a big problem still today in 2015, and it's one that causes serious adverse events. Here you see, based on the REACH registry of 31,000 real-world patients with either coronary disease or a lot of risk factors for coronary disease, you see those who've had a history of either an ischemic event at least 1 year prior, or have had coronary artery disease without a history of ischemic event, but that's stable. The risk of death, MI, stroke is about 3 to 4% a year. And if you include hospitalizations, the event rate is in the range of about 8% or so a year. So patients with stable coronary disease do have problems. It's just a matter of when. For the rest of the talk, I would like to discuss some of the findings this past year in 3 areas. One is the diagnosis and risk stratification of coronary disease, focusing a bit on CCTA. Number 2 is talk about some of the developments in optimal medical therapy, a lot of action there, and then talk a little bit about revascularization and who and how, basically because it's an important area that we continuously need to revisit. First of all, a little bit about the diagnosis and risk stratification of stable coronary artery disease. We have a whole slew of tests to choose from these days in terms of evaluating a patient with suspected coronary artery disease, ranging from echo, the least invasive, to invasive angiography. A lot of these tests are functional tests, looking for actual ischemia or surrogates of ischemia, like myocardial perfusion. A couple of these tests here, CCTA and invasive angiography, actually look at coronary artery anatomy. There is a question of, it's been a long-standing now question of what's better in terms of evaluating the patient with coronary disease? Is it functional tests or coronary anatomy? In this sub-study of the COURAGE patients, 621 subjects who both had myocardial perfusion scanning as well as coronary angiography were evaluated. And based on their outcomes over the 7-year follow-up, you can see that myocardial perfusion imaging did not separate out patients very well in terms of risk, whether they had small amounts of myocardium that were ischemic or large amounts of myocardium that were ischemic, whereas coronary angiography did prognosticate patients pretty well in terms of their risk, whether they had fewer segments involved with coronary disease or more segments of heart arteries involved with coronary disease. So at least in this small subgroup analysis, coronary anatomy was the victor over ischemic burden in terms of predicting freedom from MACE. Now, I think this is just one small study. A bigger study was embarked upon by the NHLBI and published this year called the PROMISE trial, looking and comparing CCTA in the evaluation of patients with stable coronary disease versus functional testing. Actually, 10,000 patients with suspected stable coronary disease were enrolled. They had intermediate risk of having disease. They were randomized to either getting CCTA as their initial evaluation test or functional testing. Primary endpoint was death, MI, acute coronary syndrome, or procedural complication. Here you can see what happened immediately after the testing. The CTA group had a little bit higher chance, about a 50% higher chance of needing a heart catheterization, although there was less chance that those catheterizations did not show obstructive disease. But anyway, they had a little bit higher chance of needing heart catheterization. They had actually double the chance of needing revascularization with about twice as many PCIs and about twice as many CABGs, although the absolute rate is relatively low. They had a little higher dose of radiation, but comparable to the functional testing group. Interestingly, if you looked at those patients who had functional testing by myocardial perfusion imaging, the radiation dose in the CCTA group was less than that received by the myocardial perfusion imaging group. While those who had functional testing by dobutamine stress echo had a much lower absolute radiation exposure and a much lower radiation exposure than those patients who got CTA. The outcomes are seen here. Really no difference in death, MI, ACS, or procedural complication through about the 2.5-year mean follow-up of the study. The event rate was a lot lower than anticipated by the investigators. They thought it was going to be more like 8% up here, whereas they got 3%. So in some ways, the investigators felt like this was underpowered relative to potential possible important differences in the two groups. That being said, we have 10,000 patients here randomly allocated to CTA or a functional test, and it seems overall to me like CTA is a reasonable coronary disease evaluation strategy based on these results, although it clearly results in more invasive coronary angiography and revascularization, and to what end we don't see here. That brings me to the remaining questions for CCTA, at least in my mind. Did this extra revascularization lead to improvement in angina, an improvement in quality of life? I suspect that data is had by our investigators, but to my knowledge it hasn't been released yet, and I'd be very interested in seeing that. Intriguingly, the question of does CCTA reduce MI came to my mind. The secondary outcome of death or MI was actually lower in the CCTA group compared to the functional arm. Modest amount of events due to a low overall event rate, but statistically significant. This was also seen in the very large Scott Heart study, which also compared CCTA to standard evaluation of patients with suspected coronary disease. Once again, less death and MI in the CCTA group as compared to the functional group. So marginally statistically significant, but the bottom line is it would be a good question for us to try to answer, and maybe the rescue study, which is one of Art Stillman's studies that's going to be coming out soon, will help us answer that. Another CCTA versus functional studying group study that's going to be published soon. What about the downstream effects of CCTA? In my experience with CCTA, you get a lot of patients who get a lot of incidental findings. It was 38% of patients in the Scott Hart study had incidental findings on their CCTA, unrelated to coronary disease. This can be good. Maybe they find a hiatal hernia that could explain chest pain in a patient who doesn't otherwise have coronary disease. This could be bad. Chasing asymptomatic incidental pulmonary nodules with repeated testing and biopsies can be bad for the health to some degree. It's hard to know where that all falls out, and more follow-up on these CCTA patients to see what that incidental findings come out to would be interesting to me. Should we be using more stress echo than MPI? If you noticed, only 1 out of 10 patients who were evaluated with intermediate risk for coronary disease who were evaluated actually had a positive test. That means 9 out of 10 are getting substantial amount of radiation along with their clean bill of health. And the question is, should we be using more? Should we be focusing more on radiation-free testing like dopamine stress echo if we're going to go the functional testing route to spare our patients the extra radiation in this day and age where we're worrying about the cumulative effects of radiation from medical testing on our patients? Last, I would ask the question of what will FFR, CT-derived FFR, add to the CCTA strategy. We had one study that was published this year called the Platform Study that looked at this, a much smaller, non-randomized European study than the Promise study. It was, again, small, non-randomized. There was 2 cohorts of patients. One was a group of patients that was planned to be evaluated non-invasively by their physicians for coronary disease. 100 of those patients were sent for this non-invasive testing, whereas another 100 or so were sent for CT-derived FFR. 12 out of the 100 who got non-invasive testing got invasive catheterization, with the 5 getting revascularized. In the CT-derived FFR group, 19 actually got invasive catheterization, with 10 getting revascularized. These numbers are very small. They're not statistically different, but there's, again, a tendency for the CT-derived FFR group to have more invasive catheterization and revascularization. The actual primary outcome of the study was invasive catheterization without finding obstructive coronary disease, and that was about the same in both groups. There was also really no difference in cost of evaluation of the patients. There was an intriguing increase in quality of life as measured by the Seattle Angina questionnaire in the patients who got the FFR CT. Is that because of the more revascularization? Hard to know from such a small study. There was also this invasive cohort where we all have these patients where we think they need to go straight to heart catheterization for evaluation of their coronary disease. About 200 of those patients were actually sent for catheterization, whereas another 200 similar patients were sent instead for, again, CT-derived FFR. Of course, all the patients sent for invasive catheterization got it, and about 60 got revascularized, whereas in case of being sent for CTA, only about a third of the patients actually ended up getting catheterization, with a similar amount, 60, getting revascularized. So in this case, the invasive catheterizations without finding obstructive disease was much higher in the patients who went straight to the cath lab as opposed to who got CT, but very high rate of non-obstructive disease in patients in this group of patients who went straight to the cath lab, more than I would expect in usual practice. But still an advantage here for the FFR CT group. Cost was, of course, lower in the FFR CT group because of the high cost of invasive catheterization with no real difference in quality of life. I think, what does this mean for CT-derived FFR? I really think we need larger studies looking at clinical outcomes at the end, maybe even similar to a PROMISE level study. We probably or might need refinement of FFR derived from CT, as we did not see what I would have hoped for would be a reduction in the catheterization rate in the FFR CT group. But that being said, I don't think it's ready for prime time, but it's certainly ready for further consideration. A little bit about optimal medical therapy. A lot actually about optimal medical therapy has come out in the last year. These are the stalwart drugs for we consider to be optimal medical therapy: aspirin, statins, ACE inhibitors or ARBs, and beta blockers. These four classes of drugs are considered to be optimal. What has been shown this year is that not all of our patients are getting optimal medical therapy. This is a registry of patients in Ontario who had stable ischemic heart disease and were getting their first angiogram. OMT in this study was defined as statin plus ACE inhibitor or ARB plus a beta blocker. Aspirin, unfortunately, wasn't in their database, but it turns out, in most studies, over 90% of patients get aspirin. So they assumed that 100% of their patients got aspirin. 20,000 patients with stable ischemic heart disease who got their first angiogram were evaluated for the occurrence of medical therapy, optimal medical therapy specifically, at 12 months. As you can see here, whether the patients got medical therapy after that angiogram or revascularization after that angiogram, only about 60% were getting optimal medical therapy, 40% not getting optimal medical therapy. Then those patients had a 2.5-year follow-up during which outcomes of mortality and non-fatal MI were looked at. And it turns out that the patients who got optimal medical therapy had a substantially lower mortality compared to patients who did not get optimal medical therapy, and similarly had a lower incidence of non-fatal MI than those who got no optimal medical therapy. So again, this study shows that A, our patients are not all getting optimal medical therapy, at least not at the levels we would hope they would be, and B, that optimal medical therapy seems, at least in this observational study, to be associated with a big reduction in events. This is a registry. Here is an evaluation of a bunch of study subjects, namely those from the Syntax study. All these patients had pretty bad coronary disease, either 3-vessel or left main disease, and were revascularized with CABG or PCI as part of the study protocol. Motivated patients, as they all enrolled in the study. How was optimal medical therapy used in these group of patients during their 5-year follow-up? Well, again, it was underused. Less than 50% of the total patient population was on optimal medical therapy at any given time after their initial study-related revascularization, and that seemed to go down with time, and it was particularly low in the CABG group. And yet, optimal medical therapy, again, was associated with better outcomes. It was an independent predictor of survival with about a 50% risk reduction compared to those not on optimal medical therapy, and about a 30 to 40% risk reduction in terms of the combined endpoint of death, MI, CVA. This time, again, optimal medical therapy was defined as an antiplatelet agent, a statin, an ACE inhibitor, and a beta blocker. So we're seeing similar results, and here you see the benefit incurred by the individual components of optimal medical therapy, and associated risk reduction of 30 to 80% depending on the drug. So again, most patients, many, if not most, are not getting optimal medical therapy, and despite that, it is associated with much better outcomes. What are the barriers to optimal medical therapy implementation? I mean, one is the fact is that some patients have contraindications to one or more of the components of optimal medical therapy. A patient who has angioedema from an ACE inhibitor can't have an ACE inhibitor or an ARB. But there's probably other barriers that are surmountable. Probably providers and patients don't universally appreciate the value of optimal medical therapy. Not all the guidelines are well disseminated, and certainly the patients don't necessarily understand those guidelines. there's probably insufficient prevention-focused outpatient care. It seems like every time a patient comes into an office visit, he or she has a problem they feel that they want to deal with, as opposed to a number of LDL or a blood pressure number that they care. And this is distracting from the process of dealing with and implementing optimal medical therapy. There's a patient resistance to taking medications. Pretty universally, they don't want to add medications to their list. And finally, there may be a lack of OMT implementation strategies. It's actually not trivial implementing optimal medical therapy. For example, there's the statin-associated muscle symptoms, which occur in anywhere between 7 and 30% of patients who try statins. These are real muscle pains in patients who try statins and often lead to the discontinuation of statins. But there's a strategy, which I think many practitioners here know, of getting these patients to take statins without problems. The European Atherosclerosis Society came out with this nice algorithm, which they published this year, which shows you a symptomatic patient without evidence of CK elevation. He or she can have a 2 to 4 week washout from the statin, and if the symptoms persist, it probably wasn't due to the statin, and they can be reinitiated on the statin. Alternatively, if the symptoms improve, the patient can actually then start taking a different statin, and usually they will remain symptom-free and be able to continue that statin. If the symptoms recur, another washout period, try at a third statin, or even to try at alternate day dosing or once, twice weekly dosing. Even patients with muscle pains who have CK elevations can often be reinitiated on statins, this time after a longer washout period and a more careful reinitiation of a second statin, again at potentially the lower statin dose or the once, twice weekly dosing regimen. But the bottom line is that over 90% of patients who have these statin-associated muscle symptoms can successfully resume a statin. But this obviously takes a lot of work, a lot of visits, and it's probably hard to do in our healthcare system. And unfortunately, optimal medical therapy is probably getting tougher. I'm sure most people here are aware of the SPRINT trial released this fall, another NIH study with about 9,500 patients who had high blood pressure and a high risk for cardiovascular disease. Actually, 20% of them had cardiovascular disease. Diabetics were excluded because they had been included in the other NIH study, the ACCORD study, which looked at the same subject of blood pressure reduction, namely a goal blood pressure of the standard 140 millimeters of mercury systolic versus a more aggressive blood pressure reduction to 120 millimeters of mercury systolic. Patients had monthly study visits to help achieve their target, and the study was stopped early. Here is the blood pressure difference in the standard versus aggressive blood pressure therapy groups, so 136 versus 121, with the standard therapy group having an average of about 2 medications, and the aggressively treated group having on average about 3 medications. Here you see the outcomes at the end of approximately 3.5-year mean follow-up: cardiovascular death, MI, CVA, or acute coronary syndrome. There was a 25% reduction in these events in the more aggressively treated patients, about a 1.7% or so absolute risk reduction at 3.5 years. This was accompanied by a similar reduction in all-cause death, all very statistically significant, and the reason that the trial was stopped. This benefit was seen across the board in all subgroups, including those with prior cardiovascular disease. Here you see a drill down on the actual benefits of the intensive blood pressure control strategy. Intensive blood pressure control led to less death, specifically less cardiovascular death, and in particular less CHF episodes. There was a trend towards less MI, but no difference in stroke, no difference in acute coronary syndrome. There was no worsening or benefit to the development of severe renal failure chronic severe renal failure. Here are the risks that go along with this very intensive blood pressure control strategy. No real difference in overall serious adverse events during the study period, but more serious adverse events due to blood pressure medications, specifically more hypotension and more significant electrolyte abnormalities and more episodes of AKI. So this shows you that we can get better outcomes with more aggressive medical therapy, but it's not cost-free by any means. There's more side effects. Certainly there are going to be more resources needed, more medications, more office visits to get to the goal and to deal with these problems that come up. People argued that, well, the ACCORD study, which looked at the same intensive versus standard blood pressure treatment in the diabetic patients, did not show a benefit, and wondered about the veracity of the SPRINT study or the applicability of the SPRINT results to diabetics. But I think it's important to remember that the ACCORD study was a study about half the size of the SPRINT study, so it had less power to show a difference. In addition, it did show a significant trend towards a difference. It wasn't significant, it was a trend towards a difference in the primary outcome of reduced MACE with the more aggressive blood pressure lowering strategy. And if you see a combination of SPRINT and ACCORD, sort of a statistical combination, kind of a meta-analysis type way, you see that overall with the combined results of SPRINT and ACCORD still show a benefit in terms of reduced MACE, reduced heart failure, and actually now reduced stroke. So I think, I think we're going to see this SPRINT is likely to change our guidelines. It's likely to increase our need to work harder on blood pressure and making optimal medical therapy even more challenging to implement. The other reason that I think optimal medical therapy will be more challenging and yet more beneficial is the addition of some drugs to the optimal medical therapy regime. P2Y12 receptor inhibitors, ezetimibe, PCSK9 inhibitors, and a diabetic agent called empagliflozin have all been shown to be beneficial in stable coronary heart disease. 2 studies of prolonged DAPT or DAPT in stable coronary disease were published this year. One was the Pegasus study, which looked at 21,000 patients who had MIs at least 1 but no more than 3 years prior to the patient's enrollment. So stable coronary disease patients. They were randomized to either get ticagrelor or aspirin and followed for cardiovascular death, MI, or stroke. And I think you can see here that the ticagrelor patients had less MACE, 7% or 7.7% versus 9%, about a 1.2% reduction in MACE, but at the expense of more TIMI major bleeding, about a 1.3% increase in TIMI major bleeding. Interestingly, it was the patients who, when they enrolled, had recently been on a P2Y12 inhibitor that incurred almost all of the benefit. Those who either transitioned straight from their own non-study P2Y12 inhibitor to the study P2Y12 inhibitor incurred almost all the benefit. Those who had not been on P2Y12 inhibitor at the time of enrollment for at least a year incurred almost no benefit. So what does this mean? Well, the FDA thought it meant that it was okay to give ticagrelor to patients who have chronic stable coronary artery disease, and approved it this past September. This is the DAPT study, another study published this year, looking at extended dual antiplatelet therapy in patients who received coronary stents 12 months prior. 10,000 patients who received a coronary stent 12 months prior and were about to come off their dual antiplatelet therapy were randomized either to continue their thienopyridine, in most cases it was prasugrel, in most cases it was Plavix or clopidogrel, in some cases it was prasugrel, or just continue with low-dose aspirin by itself, which tends to be the guideline recommended strategy. Those patients were then followed for 18 months, and there were 2 co-primary endpoints, stent thrombosis as well as CV death, MI, or stroke. Again, let's see here. You see here that stent thrombosis was less in those patients who continued on thienopyridine or continued on DAPT. MACE was less, both reduced between 1 and 1.6 absolute percent, and that was all at the cost of some increase in moderate severe bleeding, but less so, 0.9%. One of the intriguing findings or subgroup analysis here was that a lot of that DAPT effect was seen in the patients who had their stent placed because of an MI in the prior year. And there was a big benefit in these patients with almost a 3% reduction in recurrent MI in those who continued on DAPT versus those who just switched to taking aspirin by itself. Patients who received stents for other reasons than MI also saw a benefit in MACE, 1.2% reduction in MI, but less so. And both groups, regardless of their MI status, had similar amounts of bleeding. So again, I think DAPT has been shown now in 2 studies to have some benefit in the long term in stable coronary disease patients. This goes along with the Charisma study, which also showed DAPT to be beneficial in terms of preventing MACE in quote-unquote symptomatic patients with coronary disease. And I sort of wonder if now we're entering the official era of DAPT inertia. I think we already see this a lot in practice, but basically, are we entering the area where patients will have a stent or an MI, and perhaps at 30 days, if they're got a BMS and they're high bleeding risk, then DAPT will be stopped. Perhaps if at 30 days they need anticoagulation for AFib or a DVT, then DAPT will be stopped, and a combination of anticoagulant plus a antiplatelet agent will be used indefinitely. But for the rest of the patients, DAPT will be continued indefinitely unless perhaps they have surgery, and then it will be stopped transiently and restarted after the surgery, or if they have a bleed, and then depending on the severity of the bleed, either the DAPT will be stopped, or depending on whether the bleeding problem can be resolved, the DAPT will be stopped and restarted. I don't know, but I expect the guidelines to change in terms of our need or our recommended duration of DAPT therapy. Anti-lipid agents have also gained a new friend in terms of optimal medical therapy, ezetimibe specifically. This is actually based on an ACS study, 18,000 ACS patients who were randomized to either take simvastatin 40 milligrams or simvastatin 40 plus ezetimibe 10 milligrams. This is called the Improve It study. This study was published this year. The patients were followed up for a long time. I think the mean was about 7 years, but many patients were followed longer. And because of that, I think of this more as a stable coronary disease study for a couple of reasons. One is the patients were followed long into their stable phase, and 2 is we'll see most of the benefit occurred during the quote-unquote stable phase. Here you see the LDLs achieved, LDLs of 70 in the simvastatin alone group versus 54 in the ezetimibe plus simvastatin group, so a reasonable reduction in LDL, and this was associated also with a reasonable, although somewhat small, reduction in death, MI, CVA, ACS, and revascularization, that giant endpoint. 2 absolute percent reduction in that giant endpoint for a 6% relative risk reduction, but highly statistically significant. The benefit was greatest in the diabetics. If you look at subgroup analysis, almost all the benefits seem to occur in the diabetic subgroup and or those patients who are aged greater than 75 years of age. And interestingly, there was no offsetting side effects reported. 10% discontinuation due to side effects in both placebo and the ezetimibe arm, and this is all despite careful monitoring for liver and muscle-related side effects. So I think, that doesn't mean, to me, this doesn't mean ezetimibe for everybody, but it does mean ezetimibe for people who aren't reaching target LDLs on the highest tolerated statin doses. So I think ezetimibe certainly seemed to play a role for those patients. I think maybe the more important aspect of this study is the fact that it actually supports the LDL hypothesis. For a lot of years now, we haven't seen any other drugs that reduce cardiovascular risk except for statins. This is the first, I think, study that we're seeing where it shows an additional drug on top of a statin can further reduce cardiovascular risk. And it reduces it in line with the benefits we see from other statins based on the LDL reduction of approximate LDL reduction of 38 milligrams, equating to approximately risk reduction of 23%. So I think this is a step forward for the concept that other lipid-lowering agents can show benefit too. Which brings us to the PCSK9 inhibitors, very powerful lipid or LDL-lowering agents. Reduce LDL 60+%, even on top of statin use. We do not have definitive cardiovascular event reduction studies showing that PCSK9 inhibitors work. We have some hints. These were meta-analyses or grouped analyses of the phase 2 and phase 3 studies that were used to approve the PCSK9 inhibitors for lipid-lowering indication. They took those studies and looked for detected major adverse cardiovascular events during the studies and found that there was approximately 50% reduction in major adverse cardiovascular events regardless of the PCSK9 inhibitor used. These are, again, not definitive studies. They're small studies. They're unblinded. They're very short term. They were designed really just to look at the efficacy of lipid lowering. But I think if you have a patient who has high LDLs and does not tolerate statins at all, this very well may be a good option for him, even waiting for those larger studies. Glucose control, an important issue and a pretty big subfraction of our patients, those with diabetes, which range from anywhere between 25 and 40% of patients with coronary artery disease. We don't have a lot of data that shows that glucose control reduces these quote-unquote macrovascular events of heart attack, stroke, etc. But we do have the UKPDS data, which randomized patients to medical therapy versus oral agents, and showed that the oral agents did better in terms of reducing macrovascular events, with metformin outperforming sulfonylurea in terms of reducing macrovascular events, which has led, I think, metformin to be a first-line agent of glucose control in patients with both diabetes and coronary artery disease. This was not a randomized comparison between sulfonylurea and metformin. We do have our first randomized study showing an anti-diabetic agent does actually improve outcomes, namely a study of empagliflozin, which is an SGLT or sodium glucose cotransporter inhibitor. Basically, this drug inhibits the glomerular glucose resorption, resulting in essentially glucose wasting in the urine, as well as some volume reduction in these patients. 7,000 patients with diabetes and some form of cardiovascular disease were randomized to either getting empagliflozin or placebo. And again, we see a reasonable benefit, 14% relative risk reduction. This p-value is actually for superiority of empagliflozin over placebo, so it's actually a very statistically significant benefit. We also see benefits in the individual outcomes of cardiovascular death, all-cause death, and CHF hospitalization. The mechanism, I think, is mysterious. Is it due to glucose lowering? Is it due to the decreased blood pressure or the increased HDL seen with empagliflozin? I don't think we know. I found that the blood pressure reduction was interesting and substantial in those patients taking empagliflozin, almost a 5 millimeter reduction beyond the standard blood pressure of 135 that was seen in the standard therapy group of the SPRINT trial. So, maybe a lot of this is mediated by blood pressure reduction. Hard to know at this point. We do have some other studies with other drugs from this class of SGLT2 inhibitors coming out, so we'll be able to see if this is a class effect and maybe get some more insight into the mechanism by which empagliflozin works. What about revascularization? Not so much activity this past year. I think a lot of us are relying on at least I am relying on the BARI-2D trial, which took 760 patients with diabetes and coronary disease who were actually referred for CABG as a subgroup of the BARI-2D trial, and randomized them to either continuing OMT or CABG plus OMT, and the OMT was very good in these patients. Over 90% of them were on all 4 agents of OMT, and despite this, like the trials from the 70s, there was a benefit in terms of hard outcomes from the cabbage group with reduction in death, stroke, or MI. I think this indicates that even patients with stable coronary disease and minimal symptoms can benefit from cabbage if they have a lot of coronary disease. The 15 or actually 12-year follow-up on the COURAGE data was published this year. Remember, this is a 2,300 patient cohort group who were randomized to either OMT plus basically bare metal stenting versus OMT alone. No difference at initial outcome at about 3 or so years, and no difference at 12 years in terms of death between the two different strategies, PCI plus OMT versus OMT alone. Not too surprising. I think when it comes to PCI, we're still working based on the FAME2 data, which did show a benefit to PCI on top of medical therapy alone. Here you see PCI plus medical therapy brought the primary outcome down from medical therapy alone substantially. This outcome, by the way, that looking at is death, MI, urgent revascularization, almost all of this difference was due to a reduction in urgent revascularization. No difference in this small study seen in terms of death or MI, a small study that was stopped early. Here you see the cumulative reduction or cumulative urgent revascularization that occurs in the PCI plus medical therapy group and the medical therapy alone group, 4% in the PCI group versus 16% in the medical therapy group. Urgent revascularization triggered by ACS was actually also significantly reduced, and maybe if this trial had been bigger or longer follow-up had occurred, we would have seen a statistically significant difference in some of the hardest outcomes that mean the most to us, like recurrent ACS or MI. Hard to know. This brings us to the design limitations of these prior trials. Low-risk patients in COURAGE and all the trials, COURAGE, Berry-2D, and FAME2 were mostly what was included. Revascularization procedures in COURAGE and Berry-2D were really not optimal by today's standards. No D or little DES was used, and no FFR guidance was used in the COURAGE or Berry-2D trials. There was a major referral bias in these studies in that all the patients were randomized after catheterization, meaning that when physicians thought they knew what to do after catheterization, they did not randomize the patients. And then the small sample size of FAME2 I already mentioned. The ischemia trial will hopefully address at least some of these limitations. In this trial, patients will be who have moderate or severe ischemia by functional study will actually be randomized after a blinded CCTA, which rules out left main disease. So there will be no bias from knowing the vascular anatomy in terms of referrals. Patients will be randomized again to an invasive plus OMT strategy where everything that can be revascularized will be revascularized versus a conservative strategy where OMT alone will be used unless there's failure of OMT due to symptoms, and then catheterization will be performed. An average follow-up will be for 4 years with an outcome of CV death and MI at planned. Now, it won't address all the problems with the prior studies in the sense that still it'll tend towards low-risk patients. Here you see the major exclusion criteria: EF less than 35%, CCS3 angina that is of recent onset, meaning less than a month or less than 2 months will be excluded. CCS4 angina will be excluded. So again, they're pushing towards the lowest risk patients, and I think that's why we see what we see here, which is so far out of 17,600 screened patients with moderate or severe ischemia on functional testing, only 6,000 were actually determined to be eligible after combing through the inclusion and exclusion criteria. And of those 6,000, we're still seeing referral biases because about a third the patient refused and about a third the physician refused to randomize them. So not all of the limitations of the prior studies are being completely overcome. Here you see what our results are at the Atlanta VA, where we've been participating in the ischemia study. We have overall enrolled 69 patients, randomized 69 patients, mean age is 64. Follow-up now has been about 1 year. You can see the majority of them, 88%, are class 0, 1, or 2 angina. Only 12% have class 3 angina. PCI in about 38%, CABG in about 14%. It's a little bit more than 50%, with a little less than 50% getting no revascularization. That's because there's been some crossovers. About 13% of patients have crossed over, mostly from OMT to revascularization. No deaths so far, 1 MI, and 6 ACS events. Overall in the world, 2,500 out of 8,000 patients have been enrolled, and I think the trial will likely finish as opposed to being stopped due to lack of enrollment. While there is a question about revascularization's benefits on death and MI, particularly in patients with less than super severe disease and stable angina, there is no question that revascularization does reduce angina. That was shown in the COURAGE study. That was shown in the Berry 2D study in both the PCI stratum and the CABG stratum, and that was shown profoundly in the FAME2 study. All 3 studies showed a reduction in angina. And it turns out that, this is not an insignificant issue. 30 to 50% of chronic CAD patients do have angina more than 1 time per week. And weekly angina does predict worse quality of life. And interestingly, about half the time, the MDs of the patients consider the patient to be optimally controlled despite the fact that they have weekly angina. So there may be an appreciation for the amount of angina our patients have, or underappreciation for what can be done about it. Chronic total occlusion, PCI, has really been taking off in the last couple of years. It turns out about 20% of angiograms do show chronic total occlusions, and a meta-analysis published this year shows that CTO PCI does relieve angina better than medical therapy. This is a meta-analysis of observational studies. No, unfortunately, randomized studies of CTO PCI in stable coronary disease have been performed. The NCDR report from 2015 on chronic total occlusion PCI has shown that chronic total occlusion PCI volume has been increasing from 3.2% of the total PCIs performed in 2009 to almost 5% in 2013. I suspect it's even higher now in 2015. Procedural success has been improving from 55% to 62% in 2013. And MACE has been at least trending down from 1.9% to 1.3%. Operator volume predicts even better outcomes when it's high. CTO operators who perform more than 10 PCI years have actual procedural success of greater than 75 or about 75%, with MACE rates down to 1.4% compared to those operators who have worse procedural success rates and higher MACE rates when they do less than 5 CTO PCIs per year. So if you pick your operator and you pick the time as now to get your patient CTO PCI, chances are things can go reasonably well. Here is the CTO PCI assessment in terms of risk compared to non-CTO PCIs. You see here, again, the procedural success rate is lower than non-CTO PCIs, 60% versus 96%, and the MACE rate is a little bit higher, 1.6% versus 0.8%, but it may be a reasonable strategy for a patient who's suffering a lot from chronic angina. If a CTO PCI is not a solution for all patients, maybe this interesting device will come to fruition. It's called the Neovasc coronary sinus reducer. It's a stent that's placed percutaneously inside the coronary sinus, which restricts blood flow through the coronary sinus due to its hourglass shape, increases pressure gradient or causes a pressure gradient in the coronary sinus, theoretically or hypothetically increasing the distribution of blood flow from non-ischemic epicardium to ischemic endocardium through collaterals. Anyway, 104 patients were randomized into a study using this device versus getting a sham procedure. These patients all had CCS 3 to 4 angina. Only one paraprocedural MI was reported as an adverse event in the patients who received the reducer. Here you see there was a significant reduction in angina in the patients who got the reducer, 35% reduction of angina at least 2 classes, or 35% of the patients actually had angina reduced at least 2 classes, and 71% of the patients had angina reduced at least 1 class in the reducer group, with only 15% having 2-class improvement and 42% having 1-class improvement in the sham group. And again, an improvement in the mean change in CCS class from 3.2% down to 2.1% in the reducer group versus 3.1% versus 2.1% in the sham, 2.6% in the sham group. The bottom line is this, in a pretty well done study, seemed to reduce the amount of angina that patients had, and if CCS class isn't enough, the Seattle Angina Questionnaire quality of life went up more in the reducer group than in the sham group. Now this, I'm sure, is not enough for it to get FDA approved. It is CE mark approved, but it's not FDA approved. I think they'll have to show some objective evidence in the reduction of ischemia. And there was a trend in this small study for increased treadmill time and for, increased treadmill time is what I remember. But obviously a larger study looking at more objective evidence of ischemia will have to be made to get this FDA approved. But it at least offers some hope. So in conclusion, I would say over this year we've seen that coronary CTA is a reasonable strategy for the evaluation of patients with suspected coronary disease, but it does result in increased invasive coronary angiography with revascularization with unclear benefits, some hints maybe at improved quality of life and reduced MI using the CTA strategy, but that really needs to be more fully explored. Optimal medical therapy is underused. According to the guidelines, we should be doing much better than just 50 or 60% of our patients on optimal medical therapy. And it seems in the observational studies to have a strong association with improved clinical outcomes. So getting systems of care where we can really get closer to optimal medical therapy in more patients, I think, is very important. New medical treatments have been introduced which seem to lower risk. Ezetimibe, not a lot, but not a lot of side effect costs either. The empagliflozin and the SGLT2 inhibitor, both are medical treatments that seem to reduce risk. Strategies, as blood pressure is down to 120 instead of down to 140, seem to reduce risk. So optimal medical therapy, the bar has been set higher, and we hopefully can get more benefit overall. Routine revascularization of severe CAD, I think we all agree, is probably reduces death or MI in patients with stable angina or stable coronary disease. Its benefits in patients with less coronary disease remains yet to be defined. I think that's where our best bet is going to be the ischemia trial. And finally, angina treatment is suboptimal in a lot of our patients. And things like CTO PCI, which procedural results are getting better and better, as well as promising new devices like the coronary sinus reducer may offer a lot of relief to our patients. Thank you very much.
Thanks, Kreton. That was great. That's a wonderful overview, and for our fellows, I can tell you when I recertified in the boards a few years ago, this is an area that just got hammered in the boards, and so I hope you're all paying attention, and those of you that are recertifying, it's an area that probably the vast majority, it seems like a huge chunk of the boards are on appropriately so. I'm going to start out with one question about optimal medical therapy. So we think about, aspirin, statins, ACE inhibitors, and beta blockers, and certainly the data for aspirin and statins is extremely strong. What about ACE inhibitors? A lot of that came from animal studies, and then, when we found out that, well, if you combined it with statins, maybe that effect wasn't so great. I noticed you had one slide there indicated, what the potential contribution is, but, how important are ACE inhibitors, ARBs, in our current optimal medical therapy? How big a component is that?
Well, I think a lot of patients with stable coronary disease have pretty decent, reasonably strong indications for ACE inhibitors. A lot of our patients have diabetes. A lot of our patients have somewhat reduced EFs. A lot of our patients have hypertension. All those patients, I think ACE inhibitors have been shown to benefit even outside of the stable coronary disease realm. And so, should all patients be on ACE inhibitors? A patient who has stable coronary disease without all those things? I don't know. One of the things you're seeing with the SPRINT results is that lower blood pressure may be better, and maybe the benefit of ACE inhibitors across the board is simply the fact that you're getting more patients down to lower blood pressure. Those are good questions. That do we really need to get 90+% of our patients on ACE inhibitors? Is that really what's going to make the difference, or is 70% good enough? And I don't know the answer to that question.
We'll always do that. We got one there. We'll do that. Can you see that one? Shown in the, I guess that's the SPRINT trial. Lower blood pressure group received 1 extra blood pressure measure as an average. Is there a sub-study comparing medications used in the 2 groups, and could decrease in mortality due to the additional medication used independent of blood pressure?
That's a fantastic question. I'm not aware of the results of that. If a sub-study showing us which medicines were used in which patients, and is there an association between a particular medicine? I'm not aware of any results on that.
I just follow up on Bob's comment. I would totally agree with you, Bob. I mean, I think if you take out the patients that have a good ventricle, they're not hypertensive, they're not diabetic, and I don't see how you can put ACE inhibitors as optimal medical therapy. I think we're overextending that. Now, there might be some data I'm not aware of, but
so in my experience with trying to initiate optimal medical therapy in the ischemia population, where we're really held to the high standards with outsiders looking over our shoulder telling us, why isn't this guy an ACE inhibitor? I've asked that question myself. And for all those reasons, if you include hypertension, you've got 80 to 90% of your patients on ACE inhibitors right there. Now, if you exclude hypertension, we still have probably 50, 60% of our patients for just diabetes, renal insufficiency, probably 60, 70% of patients for diabetes, renal insufficiency, or a decrease in LV function on ACE inhibitors. So yes, I think our patient care still should be patient-centered. It's not about achieving goals on a quality spreadsheet. But I think that ACE inhibitors could be potentially better used. It is probably the weakest of the 4 drugs in terms of showing.
As I see it, you're using them for other reasons. I mean, you're using them in coronary patients, but you're using them for other reasons.
That's right. Yeah.
And my other comment is the SPRINT trial bothers me, just trying to get people down to that level. I find they're on multiple medications. They come back. They're not taking them regularly. That's what I see is going to be the difficulty of trying to adhere to the SPRINT results, is trying to get people down to that level.
I agree completely. I mean, it's the objective data is there. They have more problems, it's going to be an issue. And it means more individualized pushing and seeing if patients tolerate it, and some patients won't. But if we change the goal in our minds in general, I think we'll end up averaging with lower blood pressures, and that may be better overall.
Kreton, terrific presentation. In the ischemia, I can't remember whether there was any attempt to do a registry of the non-randomized but eligible people.
There is not.
Yeah, would have been great.
We do have enrolled patients who fall out from not having had from their CCTA not showing appropriate disease or other inclusion exclusion criteria. So those patients will be able to be tracked because they did sign informed consents, and their outcomes will be able to track. But of those 17,600 patients with moderate ischemia, a lot of those patients, of the 12,000 who didn't get enrolled, signed no consent. So they will not be able to be tracked in any sort of meaningful way.
The promise, the workup, whether you do CT, form or function, is fascinating. It looks like the vast majority of people who were worked up didn't have either revascularization or cath without disease. So these were all symptomatic people, but the yield in all, that whole symptomatic population was pretty small, wasn't it?
Yeah, it's about 10%.
Yeah.
It's about what I'm seeing in the nuclear population that passes through the Atlanta VA. Probably no more than 10% are having positive studies. We are ordering a lot of MPIs on people who have a high chance of having a negative result. And I'm back to that comment I made before. I'm really got to ask myself, is that what I would want if I was a patient, getting an MP, having a 1 in 10, 1 in 20 chance of having positive result and having an MPI, or maybe some more less radiation intensive strategy would be better. I don't know the answer to these questions. I know why we use it at the VA. There has to do with systems of care. I don't know if that's the case everywhere, but what's available is what we use. But it's got to be a big question that we should ask.
We found in Japan that there were, where they use CTA all the time, that the yield there, the people who went to the cath lab, only about 20% of them ended up getting revascularization. And the explanation was, well, we see all this coronary disease, we go to the cath lab, we don't think they need it, and we use a lot of FFR, and we do but it's, so a big shift to CTA by itself could result in a heck of a lot of people going to the cath lab.
Absolutely.
One more quick one.
Very clear. Question of laparoscopy. The question I often ask cardiologists and never get a clear answer in terms of cholesterol is in patients with high LDL, low HDL who don't tolerate statins, do you advocate putting them on Zetia alone for their cholesterol if they can't take statins?
Well, I think if that's... Pardon me? Repeat the question? Yeah, the question is for people who have high LDL, low HDL, who can't tolerate statins, would you recommend Zetia alone? I think Zetia alone would be something I would certainly try. It's a path of least resistance these days in terms of getting them on some agent. I wonder if, depending on the LDLs that we're dealing with and the coronary disease that the patient has, whether PCSK9 inhibitors might be a reasonable strategy for these patients. They're available. I have not used them myself. I haven't gone through the effort of trying to use them. I'm sure it's not trivial, but Zetia would be a reasonable choice. Depending on your thoughts, fenofibrate alone may be something you use, or gemfibrozol alone may be something you use, or in combination with Zetia also.
Thank you.
Okay. Well, with that, thank you very much, and wish everyone a happy holiday. Thanks.
The preceding program is copyrighted by Emory University.